Okay, so I know your journey has been remarkable and you're doing amazing work. I want us to also talk a little bit about what's failing global health today. I know that um, every agency that I know, every organization, students, early professionals, they are all distressed about current issues in global health. Um, so if you had to name one issue as the most urgent threat to global health right now, what would it be and why?
The answer to that question will depend on how you define things. And I think if we step back, we will say that this is an inflection point. The first quarter of this century, from 2000 to 2025, was in many ways a golden era for global health, with massive increases in investments, huge successes in vaccination, HIV, and other areas. And we're entering a new period. So I'm going to give a very concrete issue that's urgent and a very theoretical issue that I think is important. The urgent issue is malaria. The only thing that's irreversible is death. And a lot of children and babies are dying because of the rapid, unplanned, and frankly irresponsible discontinuation and disruption of US and other global support. Malaria is a terrible killer. And in many countries, when it comes to healthcare burden, malaria is king. You really can't begin to deal with other things until you deal with the high rate of malaria-related illness. It's so common in some places. I remember one community I was in, I made an unscheduled stop, a quick stop to see how a health post was doing. Very dedicated nurse. And she was doing RDTs on people who came in with fever, and she had an 80% positivity rate. And what was so remarkable about that is that the RDT had an 80% sensitivity. So essentially everyone in that community had malaria. And how are you going to deal with other things? You also have to recognize, they give kind of a saying, Occam's razor is the saying we often use in medicine and other areas, that you should find a parsimonious explanation. So if you can explain 3 symptoms with one underlying pathology, that's likely to be the right answer. But in lower income countries, Occam's razor doesn't cut it, because people have malaria and pneumonia and some other condition and some other condition. So I think in terms of urgency, nothing beats malaria in terms of the number of childhood deaths that are going to happen unless we take urgent action. In terms of a more conceptual approach, I would say our biggest challenge is the importance of increasingly using data to make decisions. Using data to make decisions. What does that mean? That means looking at what are the real causes of illness, injury, disability, and death. What are the real things we can do to make a big difference about them? Right now, there are way too many people making estimates, which are really nothing more than guesses about how big problems are. And particularly in lower income countries, I think what is going to be most transformational is unleashing the power of good data systems to empower the leaders of those countries to have real insight into what is making people sick and which of those things are easiest to control and how good are the programs to address them. This is the C part of the See, Believe, Create formula. See what the trends really are. See what's really happening with programs. See the technically rigorous pathway to progress. Use data to improve decisions. That's the bottom line in public health. If we can empower people to have data sources that are timely, valid, important, measurable, and modifiable, then we empower people to make a lot of progress. In too many countries, not just lower income, all over the place, you have assumptions of what's happening rather than facts about what's happening. Mike Bloomberg likes to say, "In God we trust, all others have to show us the data.
I think that is a good summary to the state we are in, where people make assumptions, use anecdotal stories to justify some important decisions. I think that is a perfect summary. You've also said that health progress is fragile. Sometimes I feel it's too early for us to have forgotten the lessons from COVID-19. In your opinion, what lessons from COVID-19 do you think have already faded, and what could it cost us in the next pandemic?
People don't want to talk about COVID-19. They don't want to think about it. And there are a lot of really inaccurate and frankly irresponsible conclusions. We haven't had the kind of 9/11 commission about COVID-19 that would have been so helpful. Here's my take. During the pandemic, there were fundamentally 3 phases, or at least you can think of it as 3 phases. The first phase was before we had a vaccine. The second phase was during the initial rollout of the vaccine. And the third phase was when we had enough vaccine. In each of those phases, something else was really important. In that first pre-vaccination phase, traditional public health measures, including isolation, contact tracing, masking, business closures or indoor closures, those were really important. And the countries that did better at that had many fewer deaths. So when you see these, these people with a disease that I call pontificitis, where they like to pontificate about things, where you see these journalists writing, or even public health people or health people writing, saying, it was such a mistake, masks don't work, contact tracing was irrelevant. You ask, at what phase of the outbreak? Because in that first phase, those traditional measures were extremely important, and they weren't done well in a lot of places, and they were done a lot better in other places. That second phase, when vaccines were coming in, it was a question of speed to reach the people at highest risk of death, and that's the elderly. So I think healthcare workers, you have to vaccinate because they have to care for people. But other than those 2 groups, I think it was a mistake to clutter the prioritization with the non-elderly. And the countries that did better said, we're going to vaccinate the over 80s, and then the over 70s, and then the over 60s, and then we can work on the high-risk people. Simplicity is key. And again, in that formula for better health, see, believe, create, one of the components of create is simplification. Leonardo da Vinci wrote that simplicity is the ultimate sophistication. And Steve Jobs used that in his first shareholder letter for Apple. But really it's important, because if you don't simplify, you're not going to scale effectively. So in that second phase, when we had vaccines but not enough, getting them out quickly to the people most in need was really important. One of the things that the US did do reasonably well was vaccinate people in nursing homes early on, because that was ground zero for the pandemic. And that was something that a group of us had recommended early on. The third phase was when there was enough vaccine. Then it's an issue not of speed, but of reach. How well are you reaching people who need it? And countries and parts of the US that reached a higher proportion of the high-risk people did better. So I think it's important to think a little more broadly about the pandemic, when it was a problem, which phase, what to do. By that third phase, when the Omicron variant came in, traditional public health measures were of much less importance, because it was just, a tsunami of infections. I think the 3 lessons are that we need a renaissance in public health, that we need a robust primary healthcare system, and that we need resilience in society.
Yeah, and I think you've laid it out very convincingly, because most often what we tend to do about our whole experience with COVID-19 is to lump everything together, lump all the faces together and criticize the whole thing. But I really like the way you've laid it out, from, the the perspective of the different phases and what measures we had to put in place. And I know, like, currently, public health and politics go hand in hand. And most often, especially in developing countries, we often talk about political will. And I know, like, you occasionally argue that waiting for political will is a dangerous myth. So if, let's say, government had just $1 extra per treatment dollar, what would you say should be, or should that prevention money go?
So let's talk about politics, because we at Resolve to Save Lives, one of the things we talk about often is what we call TOP, T-O-P, that we need technical rigor, operational excellence, and political savvy. The idea that medicine and politics should be kept separate is just wrong, right? I mean, what we do hope is that there isn't a partisan infestation into public health, and unfortunately we're seeing that now with some ideological approaches. But really, when we think about making political progress, this is the longest chapter in the Formula for Better Health because it's the most complicated, it's the most difficult. We are always going to be the underdogs in public health. We're always going to be underfunded, underpowered. But that doesn't mean we won't make progress. There are ways to make progress and to build confidence in that progress. That's the believe part of seed, believe, create. But the hardest part of create is to overcome barriers. And that means getting rigorous about political will. Political will isn't some vague concept. Political will is about winners and losers. Who wins and who loses from the current state of affairs and from an initiative that we're trying to get across. And how can we empower the winners and mitigate the opposition of the losers? The losers might be the tobacco companies or polluters or companies that are making unsafe vehicles. These are entities that will lose if we pass laws and regulations and implement policies that help everybody, but not as visibly. So who are the winners? Who are the losers? Who are the deciders and who are the influencers? You know, when Tabaré Vázquez became president of Uruguay, he was an oncologist, and he decided that he was going to prevent cancer not by giving chemotherapy, but by implementing the best tobacco control program in the world. And he did that. So sometimes the deciders and the influencers are going to be pivotally important. You always have to know that landscape. Which are the advocates and champions, and which are the partnerships that can make a difference? What's the timing and the pragmatism? Maybe there's an election coming and there's an opportunity to do something right now, or maybe can't happen now, but keep your powder dry, and in a year it'll happen. When I was in New York City as the tuberculosis control officer, we had been advocating for years to get our clinics renovated, a multi-million-dollar effort, and we got it approved. And then Mayor Jenkins lost the election to Mayor Giuliani. Mayor Giuliani came in, and we thought we were going to lose our clinic renovations. The New York Coalition to Eliminate Tuberculosis wrote to Mayor Giuliani demanding that the clinics be renovated. That letter triggered a response from the mayor saying, yes, we will renovate those clinics. Now, the remarkable thing was the New York Coalition to Eliminate Tuberculosis, this was handmade letterhead printed on, or typed on a manual typewriter by a person named Charles Ehlers, who was a cured tuberculosis patient. And actually, Charles was the New York Coalition to Eliminate Tuberculosis. There was nobody else in it. It was just a one-person show. So it shows that advocates can make a really big difference. And if we had to do just a couple of things, first thing you do is implement health taxes on tobacco, alcohol, sugary drinks, and unhealthy foods. That's a huge win. It gives the government lots of money. It makes people healthier and saves lives, and it reduces healthcare costs. So any government that doesn't do that is basically not taking on the killer industries. And governments that do it should be praised, and governments that don't, we need to be encouraging them to do it. Within the healthcare field, we need to look at the silent killers, especially cardiovascular disease. It's 1 out of every 3 deaths. Hypertension itself is 1 out of every 5 deaths. And yet in Africa, control rates are in the single digits in most countries.
Yeah, and I think it brings us into an opportunity to maybe highlight this double-edged sword of chronic diseases and epidemics, as you lay it out, and cardiovascular diseases still kill nearly 80 million a year, but global health sometimes still behaves like the next virus is the only threat. What would a system look like if that system truly balances both communicable and non-communicable?
I think we should focus on the word primary. Primary prevention through public health and primary care in the healthcare system. And although primary should be number 1, these are both afterthoughts. Public health is an afterthought for funding within government systems, and primary care is all too often an afterthought within healthcare systems. And a system that addresses epidemics, including the epidemic of cardiovascular disease and cancer, well, has to address both of those things. Doing the really good public health programs. You know, the modern day equivalent of safe water and safe air is actually tobacco taxes and getting contaminants out of our environment, lead, PM 2.5, and others. So that primary prevention is crucial, and yet that does take getting coalitions, being strategic, getting progress. Because if you look at still the world's leading killer is tobacco, and fewer than 1 out of 5 people live in countries that are taxing it adequately. So we're not doing a good job on primary prevention. And in terms of primary care, we're also not doing a good job. And for primary care to improve, we've been working on this at Resolve to Save Lives, partnering with countries. And we, with countries, are learning a lot of important lessons. 2 of the essential gaps are basic logistics, enough medications, valid equipment, and good information systems. When you look at the transformation, the epidemiologic transition, many conditions now need to be treated for many years or lifelong. High blood pressure, high lipids, diabetes. The systems that were set up around the world were for episodic illnesses, child illness, pregnancy. That needs to continue, but we need to wrap in long-term support, and that can only be done with practical information systems. What we see in so many countries, it's painful, is not enough medications for the most important conditions and not enough information to empower healthcare workers to support their patients. And to address those 2 things requires prioritization. Prioritization to get the medications that are most important to everyone who needs them. Prioritization to be realistic about digital connectivity, about electricity and hardware and software and what people can do in digital literacy, so that you have systems that really are able in the healthcare system to demonstrate progressive universalism, meaning you start with the conditions that are killing the most people, that we can do the most about, and you provide services to those who will benefit most, and then you expand to more conditions and more people.
Mm-hmm. And you also talk about the element of prioritization. I want us to, briefly highlight, the global backslide and the funding cuts that already happened. I know major modeling predicts millions of preventable deaths if global health funding collapses, and we are seeing it collapse in front of our eyes. What do you think is at stake, and how can we protect essential programs from political whiplash?
Well, there are no silver linings to what's happening now. We need to organize, we need to align, we need to see where there are possibilities for additional resources. Health taxes are the best way to get revenues, and then prioritization and using the formula to see the big threats, to believe we can change them and phase-wise expand that and to create a healthier future. That's the way forward to get not just through, but past this, not to build back, but build forward to more country-owned systems that use data to drive progress.